Welcome to Cancer Explained with Central Care Cancer Center. It's likely that someone you know has been diagnosed with a form of cancer. Learn more about specific cancers, their risks, signs, symptoms, and treatment options by listening to Cancer Explained.
Hello and welcome to Cancer Explained with Central Care Cancer Center. My name is Leanne Powers. I'm the Marketing Director for Central Care, and with me today is Radiation Oncologist and President of Central Care, Dr. Perez-Tamayo. At Central Care Cancer Center, we are dedicated to keeping expert cancer care close to home. We have state-of-the-art facilities throughout rural Kansas and in Missouri. So whether you need radiation or chemotherapy, a second opinion, access to clinical trials, financial counseling, or other supportive services for yourself or your family, even genetic screening for cancers, Central Care Cancer Center is here for you. At any time, feel free to email with any questions or comments. The email is askdoctor@cccancer.com. That's askdoctor, D-O-C-T-O-R, @cccancer.com. And today our discussion centers around lung cancer. It's a pretty important topic. Dr. Perez-Tamayo, I just want to start by saying, so you're a radiation oncologist. What would be the difference between you and a medical oncologist when it comes to treating lung cancer or any cancer for that matter?
Well, that's a great question, Leanne, because this is something that I hear all the time. People sometimes feel that if you see one, either medical oncologist or radiation oncologist, you've basically seen everything, and that's not the case. The focus is quite different. Medical oncology, in other words, would be chemotherapists or people that give chemotherapy, which are drugs of many sorts. It sounds scary, chemotherapy, but the reality it's a whole lot of medications that could include immunotherapy. It could include hormone therapy. It could include some other drugs that actually act upon the cancer directly. But it is what it means, that you treat cancers of any sort through your bloodstream primarily or topical. While radiation oncology is a specialty that treats patients with radiation. And radiation, again, sounds very scary, but the type of radiations come in many sorts. The ones that we offer here at Central Care is usually photons, which is a form of light. It's a spectrum of light. Or electrons, which is a form of electrical body with the atom. But the type of radiation or the mode of radiation, the technique, is determined by the radiation oncologist, which is a specialty that basically does 5 years after medical school and studies cancer of all sorts for 5 years, and then you're ready to proceed with treatments.
So this could go for any cancer, not just lung cancer too, right? I mean, as far as the differences and whether you're treated with drugs, the chemotherapy, or even the radiation.
Yes, in fact, these days, most cancers are treated with, it's called multimodality, meaning we treat with radiation, we treat with chemotherapy, we treat it jointly with both, or we treat it with surgery and everything else. So it depends on the type of cancer you have, which goes first, or if all go together. And it is the key to success. I was the principal investigator, for instance, in esophageal cancer, and was the first to publish in the world that we needed to do chemotherapy radiation up front before surgery happened to get the best results. So you can't do it nilly-willy. You really do have to do it in an orderly way in order to get the best results you possibly can.
And that's something else, going back to that whole team effort. I mean, working with other oncologists or doctors or specialties in order to get the best, I want to say service, but it's more than just service and treating the cancer.
Yes, and this brings me to a point that is so key to your success, and that is having a chart that is shared by the specialties and is kept in one place. Actually, the comparison between, for instance, different radiographic examinations and different schedules of treatment is key to knowing how well or not you're doing. And if you have it scattered throughout different centers that may not have a connectivity, it is very hard to know where you're at. And sometimes people get undertreated or overtreated or not treated correctly just because the chart has been scattered in so many places.
Now, when it comes to lung cancer, I know something that we've discussed, this topic before, but something you've always said is that by the time you have the symptoms, it's maybe too late already when it comes to treatment of lung cancer.
That's right. I was trained by the head of MD Anderson, Dr. Jim Cox, who was Mr. Lung Cancer of the world, and therefore we saw more cancers of the lung than the majority of people. In fact, I have published many papers on lung cancer. I published a significant paper on upper lobe cancers of the lung with Dr. Retsuko Komaki. And it showed us that each cancer is treated individually in a very unique way. And therefore, you have to have everybody's team together and being able to talk about it in a way that is going to make sense for you. And it's very individual. What is for you the best way may not fit somebody else. And now that we have actually targeted agents and the radiation is given in a very customized manner, it is key to the success of the program that everybody has the same intention in mind when we're treating.
Who is at risk primarily for lung cancer? Men, women, both?
Well, men are not necessarily more at risk, but there are more smokers that are men, and therefore it is still a smoker's type of cancer. We recommend that anybody that is going through a screening process with your primary care, that you ask for this by name. It is actually covered by your insurance companies and Medicare, and it has to be ordered by your primary care. So if you have a number of packs you smoke a day and you multiply it by the years of smoking, you come to a number named pack years. So let's say you smoked a pack a day for 30 years, you have 30 pack years. If you have this number of pack years in your history, then you qualify to become a patient for screening. If you are between 55 and 77, you currently smoke, or you're quit in the past, let's say 15 years ago, you can get this low dose CT scan, which is actually available not everywhere. In fact, we have it available within the Central Care family of hospitals. In Newton, for instance, in the Newton Medical Center, Kansas City, and Providence Hospital. And in fact, new on our list is Newman Hospital in Emporia. We have it at Garden City if you live in Western Kansas. And just call us and we can direct you where your closest would be. This screening CT scan is very quick. It's a 5-10 minute scan that may save your life. Because if you get a cancer of the lung that is stage 1, let's say just in the lung itself, you are almost 90% curable with different methods that we will talk about later. However, the majority of cancers of the lung are not detected at this early stage because people come in with symptoms, and those symptoms can be coughing, blood in the sputum, tiredness, and even pain. So if you come with these symptoms, it means that your bronchial tree has been invaded by a cancer to the point of bleeding, and maybe perhaps even have gone into the lymph nodes and causing pressure, pain, or obstruction. If you have these, then you become a stage 3 or even a stage 4 cancer, and your survival goes from 90 percentile down to 10%. So why would you do that when you can do an exam to prevent it? The type of treatment that is offered now for stage 1 cancer, stage 2, is painless, it's non-invasive, it's a 90% curability. Don't wait. Let's get this treatment that we need and get it done. Now let's talk about, there's 2 major groups in lung cancer. It's the non-small cell and the small cell. Small cell is just what it says. The cells are small. They look like oat. Sometimes they're called oat cell. They're treated very differently. And surgery is not necessarily the major part or any part of the treatment, even in early stage, because these cancers like to travel in the blood early on. Those are not the majority of cancers. Most of the cancers are non-small cell, and these are mostly smoking related. Now, smoking doesn't necessarily mean just cigarette smoking. It could be exposure to smoke from other things, from burning trash, from burning wood. There are some types of work-related environmentals, yes, that you can have an increased risk. And the time of exposure is key. If you were exposed as a young child to secondhand smoking, let's say your father smoked, you are at risk as well. We've had people that have lung cancer who have never smoked, and have a lung cancer that is related to smoking because they were secondhand smokers. They smoked and they were, let's say, bartenders, and they are smoking everybody's cigarette, even though they may not be smokers.
Slow growing cancer would this be non-small cell? Is it a
No? It can be. It could be indolent, meaning kind of slow growing, but it can also be very quick. There are also genetic cancers of the lung, which are part of, let's say, your risk as a inheritance. And those are called adenocarcinomas, and they're usually multicentric, meaning they present in one lung, then the other lung, or at the same time. And these are treated also differently. They can be very devastating because imagine if you have these tiny cancers crop up every so often, it can completely basically do away with your lung. So you need to, first of all, establish what kind of cancers you have. If you have a smoker's cancer and it's early, the treatment can be as quick as single fraction radiation, and that would give you 90% survival, or a surgical procedure that, again, is almost outpatient, and you would be cured. But again, unfortunately, we don't see this. 90% of the cancers that we see are already stage 3 or beyond.
You mentioned some of the symptoms include, of course, smoking, and not only just from cigarettes, but campfires, maybe some firewood or some environmental, but also radon. Would radon, if you've been exposed to those kind of situations, or even vaping? Vaping is so popular now too. I mean,
absolutely,
all of that is involved, right? As far as symptoms.
Radon is a radioactive gas that is deep usually in the surface of the crust of the earth, and Kansas in particular has a lot of radon because of the way that it is flat, unlike mountainous areas. And it is worthwhile to know if your house is exposed to radon or has been. And before you buy a house, you need to make sure that this is something you are not going to inherit in the house, because actually it can kill you. But you can fix it. It sometimes has to do with landscaping. It's easy to block if you're able to identify it. Then there's, of course, asbestos that forms another type of cancer, not of the parenchyma proper, in other words, not of the meaty part of the lung, but of the lining of the lung. The lung is lined by like a baggie. This baggie can become upset if you expose it to asbestos, and many of the old homes have asbestos-lined tubes so that initially it was thought that this would be a good thing to prevent fires because it is a retardant, fire retardant. Sometimes with the shingles or with the outer layers of the home being lined by asbestos, you are exposed. And we had one case, in fact, just recently where the only duct that was lined with asbestos was the one that went to the kitchen. And the woman who actually was a non-smoker but was a heavy cooker, loved to cook, and developed this mesothelioma, which is a cancer of the asbestos. So you do need to check these out before you buy a home, and removing it is key to you not having it or your family. So that's one type of risk that can be environmental. But of course, if you are a non-smoker and you've been exposed heavily as a young child to smoking, you can also be at risk.
So the American Cancer Society, as far as any kind of statistics go, they say by far the leading cause of cancer death among both men and women is lung cancer, making up almost 25% of all cancer deaths. And so sometimes I think lung cancer, gets pushes to the side because people think about breast or prostate, but it is just as important of a cancer that does, kill, unfortunately, for both men and women.
Well, they kill so many people that even a 10% advantage in survival by just getting it early, even just 10%, would cure more people than all the Hodgkin's and other lymphomas that are in existence, which is a very curable cancer of the nodes.
As far as symptoms too, you had mentioned a cough, and that is just such a common symptom, I think, for anything that some people might just think of it, it's just a cough. it'll go away, or I'll take something for it and it'll be fine. But if it persists and if it lingers, again, it's just so vital to get that done, that screening done. So, because the stages, like you had mentioned, stages 1 versus stage 3, your percentage of survival rate is so much greater for sure.
Well, and the symptoms sometimes have to do with where it is. If you can imagine the bronchial tree starting at the trachea, which is your windpipe, that divides into your swallowing tube or the esophagus, and then on front of it is the trachea. It divides into the left and right side, right about mid-sternum, and we call that, the carina, or where it divides into the right and left side. Each lung has about 3 lobes, 3 in the right distinctly, and 2 in the left. There's kind of a little bit of a third lobe that is a lingula, but it comes like this. So if you have a cancer that is very close to the center where the bronchial tree divides, you may have bleeding just from the cancer eroding into the bronchial tree. And sometimes, even though the location is not good, it can be seen earlier because it has symptoms. When you have something in the periphery that doesn't cause any trouble, it may grow and grow until it starts growing maybe into your ribs and then causing pain, or into your heart. And then it goes into the lymph nodes, which can also block the airway, causing pneumonia. So, sometimes the symptoms may be that you're getting pneumonias over and over again, and you don't understand why. And that's because you're not draining the mucus of your lung that normally forms, because there's a node blocking this. Or, for instance, you may have headaches with nausea for no reason, and you may not associate it with lung cancer.
I wanted to ask you, when it comes to lung cancer, and I know that you mentioned that sometimes then, of course, it'll get into the lymph nodes. So then that immediately made me think, okay, well then, yes, lung cancer could spread then to other organs easily, and cause even more problems if you're not catching it. So you can find it. I mean, you'll have experience some other symptoms that go with that.
To the bone, a liver.
Everything like that. Survival difference between stage 1, stage 3. Vast majority of patients, not candidates for surgery because it's already too late. Is that a possibility?
Well, yes, but you see, the stage 1s and 2s are cancers that are less than 5 centimeters, maybe 1 centimeter, but have no lymph nodes. You can have a lymph node around your bronchial tree because it's very close to your bronchus and still be early. But when it gets into the mediastinum, and mediastinum is exactly what it says. It's middle of you, the middle of your chest, basically underneath your sternum or your breastplate. And this mediastinum holds a lot of blood vessels and lymph nodes. And when it gets into that area, it then becomes a stage 3. So again, some cancers, because they're close to that area, can go very quickly to the mediastinum because it's a drainage, a natural drainage of the area. Or if they're peripheral, they can go to the mediastinum, or actually they can expand to the rib area. So here again, what are the 3 places that lung cancer can go? It can extend locally, meaning extend the surrounding areas. It can extend into your windpipe or your ribs and cause you pain or bleeding. It could extend into the lymph nodes. The lymph nodes are a drainage that is mainly meant for infection. But when the lymph nodes are involved, they send it to the next chain of lymph nodes through these little ducts, and then it starts spreading into the lymph node system. So you may have, let's say, a knot on top of your clavicle, which you don't know why you have that. Well, that usually is a lymph node that came from the middle, then it reached into your neck area. And then it can go into the bloodstream and reach other spots of your body, like your liver or your bone, or your gut, or your kidneys, or your adrenal glands, or your brain. So the symptoms may be not related to your lung, but maybe to an area that this went through the bloodstream.
I've heard about RET mutations as well, specifically with non-small cell lung cancer. Can you talk a little bit about what that means or what that is about?
Well, this is where the difference is huge about how to treat cancers with chemotherapy that have a mutation which makes them more amenable to certain types of chemotherapy agents. There's something called an EGFR mutation, which 20% of the adenocarcinomas will have. There's an ALK mutation that is 5%, KRAS and ROS, about 2%, BRAF and RET and PDL1. There's many, many mutations. And what does that mean? It means that this cancer has a special way that can be targeted through a chemotherapeutic agent or immunotherapeutic agent that can then turn the cancer off or kill it by other means. And this is always an advantage because then, you have kind of a key to the cancer and you can turn it off. Now, of course, if it's overwhelming your body throughout your bloodstream, it's a very hard thing to do because, again, chemotherapy's problem is trying to deliver an agent that requires blood supply to reach there. And maybe it's in between your bronchial tree and your lung. As you can imagine, if you've ever dressed a chicken, there's a cavity. So how is it going to get to a place where there is no blood supply? So that's why we have to join forces with surgery or radiation to be able to get to these nooks and crannies. But once again, these agents are available to Central Care Cancer Center, and they are prescribed by your weight and your height. So you don't have to travel to get these agents near home. And they do have their side effects that require maybe a very, very close monitoring, which means that you may have to be in the clinic every week or every other day to be seen. Maybe you need hydration. Maybe you need special support medication. And traveling when you are not in the best of shape is not always advisable. And your family support is vital to your success. So if you have it nearby, your family or your friends, or even if you want to, let's say, work, you want to be able to be getting your treatment and have a normal life.
Again, we just can't stress the importance of getting screened. And so just as a reminder, the criteria for screening anywhere from 55 to even up to 80. If you have a 30-pack history of smoking or you're a current smoker or you've quit within the last 15 years, then you qualify for that low-dose CT scan. We just always like to tell everyone that you are your best advocate and maybe making this screening part of your own wellness program, just like if you go for your mammograms, or get your regular checkups. I think that's important to emphasize. Of course, as prevention goes, Doctor, not all lung cancers can be prevented, but stop smoking should be, one, or at least control it. Maybe look around your environmental if that's something like we talked about, the asbestos or the radon, and that's something that can be prevented too. But when it comes to treatment, what kind of treatment options are we looking at?
Well, first of all, before I go there, I do want to just reiterate what you've said, but with the one extra caveat, and that is that one more cigarette may be the cigarette that is going to overflow your glass. What happens is that, like the sun with your skin, cancers of the lung are a cumulative offense to the lining of your lung. So what happens is that it's like you're filling this glass of water, and that just one more is going to turn the cells to become malignant. So yes, even though you may say, gosh, but I've already smoked 50 pack years, what the heck is one more pack? That one cigarette may be the reason why you get lung cancer. It just will turn those cells on to become unable to be stopped and become cancerous. So it is important to stop. Now, here again, the staging for curability and treatment is radical. In its results. If you are early stage, you can have surgery or ablative techniques, meaning treatments to the mass itself with stereotactic radiation, for instance, where you would need, let's say, 1 to 5 treatments depending on the size of the cancer and call it good. Your chances of cure are equal as that of surgery. There's a Journal of American Medical Association article which shows that they put them head to head, and actually you can do just as well with radiation without having to open your chest. Not to say that a robotic-assisted treatment with surgery for early stage cancer isn't good. It is very good if that's what you want, but the options are relatively non-invasive. So I would suggest that if you can do your screening and be early, then you can have a chance to choose these. Now, when we're talking about stage 3, meaning that the cancer has already gone into the lymph nodes, it then becomes very, very complicated. And here again, it depends on the type of cancer you have, whether it has certain biological factors. And we were talking about these mutations that may include some chemotherapy agents more than others. But the usual way of treating is to do radiation and chemotherapy sometimes chemotherapy first if the cancer is very large and we want to make it small enough to be able to spare as much lung as possible, or we may want to do it concurrently if the person is blocked up or is bleeding and we really have to get things going right away. Now, one has to understand that usually in these days, chemotherapy is given in a manner that gives you very little problems in that they're supportive drugs and make you able to tolerate it well, but nonetheless, it is a challenging treatment. So it is important to be a team member. One needs to be able to say, okay, I don't feel well, or I have this or that symptom. It's not necessary to be a hero. It is better to tell us what is not going right for you so that we can then provide the appropriate medication to support that symptom. These cancers also produce these juices or these humoral substances that travel through your body, and they give you symptoms called paraneoplastic syndromes, which may not have anything to do with the treatment, but can make you not feel well. For instance, there's some cancers that make you have like arthritis or muscle pain or inappropriate water absorption and deposition. So sometimes you may have symptoms related to your cancer that will go away once the cancer is controlled. Now, sometimes we do join up with surgery if it's possible, if it's resectable, and do everything, chemotherapy, radiation, and surgery to get the job done. So it depends on what you have that one would require the treatment. So we have something called concurrent chemotherapy, meaning that we give radiation and chemotherapy together. We have adjuvant or neoadjuvant treatments where we give you chemotherapy first and then see where you are and then provide radiation or surgery. And then we have immunotherapy, which is actually targeted agents, if you have that target, to treat you and see if you are able to decrease the load of your cancer to a point of resection or a point of radiation, or even indefinitely. Let's say that you are already a stage 4 cancer, meaning it has already gone into your bones or your liver, but you're responding well. You may do very, very well and continue on the drug that you're responding to.
Lung cancer, can it come back? I mean, even if you've gone through treatment, let's say you are stage 1 or 2 and been successful, but it can come back?
Yes, it can come back in two manners. One, it can come back because it never went away, meaning you have a residual cancer that just basically woke up again and started to grow again, and we may be able to target it with other agents. Or it can come back elsewhere, like with these genetic cancers where it is no longer where it started and where it was treated, but now it's in the lower lobes or the other side, and it's treated as if you never had the other one, so you actually treat it as if it was the first time around. So if it should come back, depending on where it is, the treatment would vary. And of course, if it is a small cell cancer, it is treated very, very differently. Chemotherapy is the main event on this. Radiation then consolidates or basically cleans up the nooks and crannies. And then we have to treat your brain usually prophylactically, because in this cancer, it usually goes to the brain at some point. And if we're able to treat it before it's manifested through radiographic means, we then can arrest it when it's in the microscopic stage.
One more thing I wanted to ask you, because this is something we've talked about before, but I'm always intrigued by it, that if I start smelling oatmeal, and it's kind of unusual for me to be smelling oatmeal, what does that necessarily mean?
Well, I always tell this to the patient because sometimes the symptoms you may be having may not make a lot of sense to you, or you may think of them as not important, and they are important. Smelling something that is not there can be an olfactory seizure. And it can be the first signs that you have something wrong in the brain. And if you have lung cancer, it could be lung cancer in the brain. So sometimes, holding back, this is a very common thing people don't tell us, is how tired they are. They're tired out of proportion. And this is usually a very important sign of lung cancer and of colon cancer, because usually what happens is there's anemia or some sort of loss in the of blood, either through spitting up blood or losing blood through the colon, and you become anemic, and you're actually tired not because you have done a lot, but because your blood just doesn't sustain your body. So even though it may not make a lot of sense to you, all symptoms need to be reported, even if they're just slight.
Anything else you want to add about lung cancer?
Well, to me, it's a passion. I guess I was trained by a very important leader in lung cancer, and to me, you have to look for people that are passionate about cancer, because, and especially lung cancer, because if you don't try to look at every single aspect of it, you will not reach the levels of survival that we have here with Central Care.
Thank you, Dr. Perez-Tamayo. And just a reminder, the screening criteria from the American Lung Association regarding the low-dose CT scan among those that are high risk is defined as an individual that's 55 to 80 years of age. They have a 30-pack history of smoking. That means a pack a day for 30 years or 2 packs a day for 15 years, etc. They're either a current smoker or have quit within the last 15 years. So if you are in one of those categories there, then you qualify to have that annual low-dose CT scan. That low-dose CT scan is so vital, that screening, because it can help reduce the lung cancer death rate by up to 20% actually by detecting tumors at early stages when they are more likely then to be curable. And we appreciate you taking the time to listen to Cancer Explained with Central Care Cancer Center. With facilities throughout rural Kansas and in Missouri, Central Care offers complete cancer care all under one roof, so there's no need to travel far for the best and personalized care. Whether you need radiation or chemotherapy, access to clinical trials, financial counseling, or other supportive services for yourself or your family, Central Care Cancer Center is here for you. You have a choice. Bringing that expert care to you is an important component in the success of your outcome. Being surrounded by your family, your friends, that can be the factor that just elevates your treatment. Feel free to reach out to our offices by calling 800-592-5110, or you can always visit us online, cccancer.com. For Dr. Perez-Tamayo and all of our amazing providers and nurses, I'm Leanne Powers, and thank you for listening to Cancer Explained with Central Care Cancer Center.
You've been listening to Cancer Explained with Central Care Cancer Center, offering expert cancer care that's close to home. Central Care Cancer Center has clinics throughout Kansas and in Missouri. Central Care Cancer Center, online, cccancer.com.